Hello everyone and welcome. Thank you for joining us tonight for our webinar, Teaching Registrars about Diagnostic Frameworks and Clinical Reasoning, and it's presented by Dr. Alison Miller, who's our Head of Training in the South Eastern local training area. So, acknowledgement of country tonight. I acknowledge the traditional custodians of all the lands on which we meet today. I am on Ngunnawal and Ngambri country and I acknowledge that this is Aboriginal land. We pay our respect to elders past, present and emerging, and extending that respect to Aboriginal and Torres Strait Islander people here today. And we respectfully recognise the continuing relationship Aboriginal and Torres Strait Islander peoples have with this land. So we're in webinar format tonight, and so your microphone and camera have been disabled. And we will do our best to look at what you're sending us in chat and in Q&A to address your questions as the evening goes on. We'd ask you to not participate while driving, so if you are driving, we'd ask you to pull over, disconnect, and you'll be able to see the recording of this webinar at another time. Your safety is paramount. If you want to ask a question tonight, please use the Q&A feature on your Zoom toolbar. You type in the question and click send, and we'll do our best to get through your questions. We may not be able to answer all of them, but we'll do as best we can within the time we have available. And if you do happen to put a question into chat, we will ask you to move it into the Q&A section. And tonight with me, we have Solly helping out, watching the chat and keeping an eye on things. So Alison, I'm going to hand over to you and just make sure that everybody knows there will be some time for questions at the end of the session tonight as well. Over to you. Thank you.
Thank you for having me, and I just wanted to acknowledge that I'm on Dharawal country, which is in, well, so I'm in Wollongong tonight. So hello to all the supervisors from the South Coast. It's been lovely seeing some of the names that I know that are familiar. So what we're going to do tonight is we're going to talk about the concept of dual process theory and how it impacts diagnostic thinking. We're going to talk about the concepts of clinical reasoning, problem representation, diagnostic frameworks and illness scripts in the context of clinical reasoning and, clinical supervision and teaching. And we're going to adopt these systematic approaches and try and develop registrar skills in safely assessing and managing clinical presentations. Now, the reason that I became interested in this is that as the clinical or the CCE exam has developed, this is a skill that registrars are assessed on, and it's quite overt that they are asked to give their problem representation. They're asked to give their what are their diagnoses, and they are assessed on whether or not they use a diagnostic framework when they do that. And illness scripts help them do that, and we'll have a look at that as we go through. So the next slide, please. So you're probably all familiar with clinical reasoning, but it is a cognitive process by which the information which is contained in a clinical case is synthesized. So that's all up in our brain. It's integrated with our knowledge and our experience, and it's used to diagnose and manage the patient's problem. So the clinical reasoning that one person does is going to be different to the clinical reasoning that the next person does, because our knowledge and our experience is different to everybody else's. So one person may see a patient and they'll come up with different clinical reasoning for a problem than everybody else in the room. So it's important that we teach our registrars how to integrate and synthesize using the knowledge and experience that they have. Okay, next slide, please. So we should be able to support our registrars to develop these skills because they are patient-centred. We need to teach them to tailor their questions to what the patient tells them. We don't want them to just be listing off the same 50 questions to every patient. They've got to be able to tailor the questions to what is coming out of the patient's mouth. They need to be able to be flexible. And, we don't want them to be asking an 83-year-old woman about their periods. They've got to be able to look at the demographic in front of them. And we certainly don't want them to be latching onto the first diagnosis that they think of. They need to be considering all the information that they get. They need to be able to thinking about a lot of differential diagnoses and filtering the information and discarding some diagnoses, keeping some diagnoses based on what information they are getting. Okay, next slide. So dual process is a way that doctors think. You may have read the book Thinking Fast and Slow, or How Doctors Think. So this is one way of looking at how we do think. So there's type 1 thinking, which is very, very fast. And you can see on this is the hare and the tortoise. On the left is the hare, on the right is the tortoise. And the type 1 thinking is very fast. It's really, really unconscious and it's automatic. And we just think, we don't even think, we just automatically jump to conclusions. But it's quite error prone. Type 2 thinking is very, very slow. It's very conscious. It's deliberate, and that's how we make our complex decisions, and it is much more reliable than type 1 thinking. And if we go to the next slide, there's just another way of remembering it. This came from the I Am Reasoning podcast. So Nick Sheckett, who's one of the presenters from that podcast, did give me permission quite a long time ago to use this analogy. So type 1 thinking is like, the cowboys in the old Western movies. You know how they turned their backs on each other and they walked, however many paces, and then they turned around and they whipped out their guns and they just shot. They didn't have to think about it. They just went turn and bang. So it's very quick. It's reflexive. There's not much thought. Yes, exactly. Go ahead and make my day. So they just go bang. They don't think about it at all. And type 2 thinking is like the sniper. They have to get the distance right, the temperature has to be right, the wind has to be right, everything has to be absolutely perfect before they make that shot. So it's a very, very slow, deliberate and thoughtful way of shooting. So type 1 versus type 2. So then we go on to having a look at if we hear a child come in with a wheeze, type 1 is, we think, that's asthma. But if we were to look at a type 2, we would analyse it and we would think, well, is it asthma? Does that child have a foreign body? Is it anaphylaxis? Is it a viral induced wheeze? So we have to be, we think about it, we process it, and we come up with a few more differentials before we actually make the diagnosis. So a couple of little quizzes. The next slide. What's that? Type your answers in to chat. Yeah, so you didn't have to think about that. You just looked at that and it was just pattern recognition. You all knew that it was shingles or herpes zoster. There's no thinking about it. You didn't have to take a history, do a full examination. You just knew it. It was pattern recognition. It was just really reflexive. And then the next one, what's that? Yeah, so again, really reflexive. You look at it, it's pattern recognition, no thinking, it's rheumatoid arthritis. And then we come to the next one. What's the diagnosis? And I'm going to preempt it because there's no magic diagnosis for that one. We all have to, sleeping sickness, yeah. Yes, exactly. It's a long illness. It's a long list. We have to go to our type 2 thinking to make a diagnosis for that. We have to do a history, we have to do an examination, we have to do some investigations, and there's lots of possible diagnoses for that one. So we have to, so if someone comes in and presents to you and says, I'm tired, there are, it's endless possibilities. So we have to use our type 2 thinking. So when we're looking at good clinical reasoning, there's 3 steps. The first step we go through is we name the problem, and that's called problem representation. The second step is we work out the problem, and then we use our diagnostic frameworks and our clinical schemas. And then step 3 is we make the diagnosis and we use our illness scripts to do that. And I'm going to go through and talk about each one of those steps. I've just put the little logo there for I Am Reasoning. If you haven't heard the I Am Reasoning podcast, it's a great podcast. They don't make it anymore. They had about, I think 5 years where they made that podcast, and it's really good to talk about clinical reasoning, but you can still get it on most of the places where you get podcasts, and I love it. I've listened to it about 3 times. It's really well worth listening to. So let's go and talk about problem representation. The vocabulary that we need to know, a problem representation is a short summary of the most essentially diagnostic features of the case. A diagnostic framework is a structured diagnostic approach to the problem, and an illness script is a structured mental summary of a specific disease. Okay, next slide. I just want to throw one of my little quotes in here. So if you listen to the patients carefully enough, they will tell you the diagnosis, which is William Osler. That's true most of the time. Not always. Sometimes there's conundrums and we don't know what the diagnosis is, but most of the time they tell us what's wrong with them. Okay, problem representations. Now, we need to know what these are because they do ask this in the CCE. The question will be, what is your problem representation? So this is linked to hypothesis generation, and the registrar, or even we, use these as guides when we're making our diagnosis. So we have a problem and we distill it down into its relevant features, and the patient will come in and they'll say to you, I have got, a sore tummy and I've been vomiting up blood. And so what we're going to do is we're going to translate that into medical terms. And we're going to say the patient has epigastric pain and they have hematemesis. And this makes it more efficient to make a diagnosis and to choose what illness script we're going to use. So we abstract information from the patient's history using semantic qualifiers, which I'm going to talk about in a minute. And the problem representation is dynamic, which means it changes depending on what information we get, and it can change as the history goes along. Semantic qualifiers, they're usually paired. Sometimes they're sets of 3 opposing descriptors or words that we use, and we all use them, but you probably may not have known what they were called. They're used systematically to compare and contrast diagnostic considerations. I didn't know what they were until a couple of years ago either, but obviously I'd used them since I was in medical school. So proximal, distal, acute, chronic, sharp, dull, etc., etc., etc. So when we're using our problem representation, we use these words to describe what the problem is. So we say, Mr. Smith came on with acute onset of epigastric pain and hematemesis, or you can say he has had subacute onset or subacute epigastric pain. and it just gives you obviously a different picture. Okay, so next slide. So when we're trying to make up a problem representation, the three main questions you want to ask or answer in your problem representation is who is the patient? So any relevant demographics, any relevant epidemiology or risk factors. When did this happen? So the temporal pattern, so the duration and the tempo. And what is the clinical syndrome? So who, when, and what. Next slide. So let's talk about this patient. So Mr. Richard Davies comes to see you. He's 56. You know him well. He's unemployed and he lives with his daughter's family. You're aware that he drinks a lot of alcohol. He has about 1 bottle of whiskey every day. He smokes 1 packet of cigarettes every day. So he tells you he's been having pain high up in his belly for the last few weeks. And last night he vomited up some blood. So when you question him, he also admits to having had black bowel motions for several weeks. So his pulse rate's 120, his blood pressure is 80/50. He looks pale and unwell today, and he says that he also feels a bit dizzy when he stands up. Can we have the next slide? I might have to go back. I can't remember what's next. Okay, all right. So his problem representation, it's an ambulance deficiency disorder. So who is he? He's a 56-year-old man. He's Richard Davies. He's an alcoholic and he's unemployed. So he's had a few weeks of epigastric pain and melena, which is subacute, and he's had 1 night of hematemesis, which is acute. And then he's had epigastric pain, melena, hematemesis with tachycardia and hypotension. Okay, so now remember, we don't want to put things in there that we don't know what the diet. We don't put things in there that we haven't diagnosed yet. So all we talk about is what's presented to us. We're not making a diagnosis yet. So it's just a representation of what the problem that's presenting to us is. So we've got the next slide. So when we're trying to get the registrar to give us a problem representation, we get them to use semantic qualifiers. So, so we use it's acute versus chronic. Is the pain sharp or is it dull? Is it episodic versus constant, etc. So encourage the registrars to use these words rather than, oh, he's got a bit of pain and it's been around for a little while. Make sure that they're using the semantic qualifiers. Make sure that they keep the problem representation updated. So you first up got an elderly male with acute hypoxic respiratory failure from a community-acquired pneumonia. And then when he comes back, he's an elderly male with improving community-acquired pneumonia, now found to have acute diarrhea. And then you're lowering the cognitive load by actually translating the data into the clinical syndrome. So pain with inspiration is pleuritic pain. So you're using all of the medical words that that are needed. It's difficult to do it to start with, but you just got to keep trying. And if it's difficult to come to a diagnosis, just change the input to see if it changes the output. Okay, let's go to the next slide. So does anyone want to have a go at doing a problem representation? Putting it into chat? I think Solly might read out a couple. Okay, so we're not actually making a diagnosis. We're summarising the presentation.
So we have a 56-year-old male with epigastric pain associated with hematemesis and melena. Is one of the first ones that came up.
Yeah.
To be fair, it's so much harder to type it down sometimes than to say
it. Yeah, because it's Right, let's have a look at the next picture, which has got a summary. Oh, you can't remember the yeah, I know, sorry. Okay, Richard Davies is a 56-year-old unemployed alcoholic man who presents today with subacute symptoms of epigastric pain and melena and acute hematemesis. And on examination, he's hemodynamically unstable. Yeah, that's a good one. 56-year-old man with alcohol-related hematemesis and melena. So basically, it's just one or two sentences that you pull out of what presents to you, but you're not at this stage making a diagnosis. So you're just summarising the presentation. You don't know that he's got liver cirrhosis, and you don't know that he's got esophageal varices just yet. It could be esophageal varices. That is absolutely true, but it could also be a bleeding ulcer. So you've just got to be careful. At this stage, it is just a summary of the presentation. We'll move on to the diagnosis later. Can we have the next? Yeah. Does anyone have any questions so far about problem representations? I know it's a new concept, and it took me a long time to get my head around it, but they're definitely using them in the exam. So it's worth reading about them and thinking about them to try and teach your registrar if you've got someone sitting the CCE at any stage, and trying to get them to do it from the beginning of GPT-1, because they are actually very useful.
So Alison, there's a question here. Could you have said he is shocked?
Yes, you could say he's shocked. Yeah, I said hemodynamically unstable, but you could definitely say he's shocked, because you could also say he's tachycardic and he's got a low blood pressure. Yeah, so shocked, hemodynamically unstable, tachycardic, hypotensive, whatever medical words you want to use that would describe the situation he's in. Okay, let's do the next. Okay, so diagnostic frameworks. Again, I didn't realise that I was doing this until just recently, when I started listening to the I Am Reasoning podcast. And I think we all probably do it. Some of us know we're doing it, some of us don't know that we're doing it. So we're often taught diagnostic schemas for particular illnesses. So this is a diagnostic schema for an upper GI bleed. Now, I don't know about you, but I cannot keep in my head a diagnostic schema for every single condition. So I can't keep a diagnostic schema for an upper GI bleed, for heart failure, for, can you go on to the next one, please, Sarah? Here, for shortness of breath, that one is so complicated. I mean, if you've got a book when you've got them all in, that's great, you can look them up, but I cannot keep that in my head. The next one, good, no, neither can you. This one's for altered mental state. There's no way I can remember that. And then let's go on to the next one, because someone's preempting what I'm going to say. So these are the diagnostic frameworks that I use. I find the biopsychosocial one particularly useless. I went to a workshop at a conference once, and they divided us up into 4 groups. They gave us a problem to, a diagnostic dilemma, and got each one of the 4 groups to use one of these diagnostic frameworks. And we all came up with the same list of diagnoses. But I find the biopsychosocial one particularly difficult to use, and it's very, very long-winded. And what I tend to do is I cross-reference Murtaugh's prompt with Vindicate. So if I want to be really quick, I use Murtaugh. If it's a problem that I'm really struggling with, then I would use Murtaugh and Vindicate as well. So you may not have heard of these before. Vindicate is called the surgical sieve. There's another one called vitamin C, D, E, which is similar. So it's, it's got vascular, and it's got a few other bits and pieces in it. So you may want to look that one up. But we'll go through Murtaugh's prompt because it's actually really useful. And I find that registrars actually do much better at making diagnoses when they've got a framework to use.
Alison, we just have a question.
Yeah.
How time consuming is the slow thinking pattern?
With using one of these?
I think generally, if you know, whether you're using your fast or your slow, how much extra time or how much time is being consumed if you go to that more thoughtful and
I
type 2?
I think that question is like, how long is a piece of string? I think it depends on each individual. I think it depends on the case, and it depends on how experienced you are at using it. So when you first start using it, it can take a couple of minutes. It depends on the problem. So if you've got something that's really tricky and you have absolutely no idea what's going on, sometimes I might sit down with a pen and paper and actually work it through on pen and paper. Sometimes I can just quickly say in my head, the more practice you have, the quicker it can be, and it can just be 30 seconds. You know, it can just be, what's probability diagnosis? What are the red flags? Blah, 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 blah. No, I don't think it's that red flag. I don't think it's that red flag. It might be that one. It might not be that one. Blah, 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 blah. And it depends on the case. Yeah, just depends. So this is the going through the probability diagnosis. So the P for prompt is the probability diagnosis. Now, the red flags, I think, are really important. And I emphasize with the registrars, they have to know this. There's 2 M's and there's 2 I's. The 2 M's are malignancy and metabolic. The 2 I's are infection and infarction. And I will talk about that in a minute. There's the often missed, and there's a slide on that which is coming up. And there's the 7 masquerades. And again, I encourage you to learn the 7 masquerades and teach them to your registrars and get them to learn them, because they are often missed. You know, people are often taking drugs, and you can put alcohol in with drugs. They often have diabetes. They're often depressed. Spinal cord dysfunction I haven't seen so often, but it's in there. Often thyroid, often UTI, and often anemia. And is the patient telling me something? I mean, how many times has someone come in and it's domestic violence? How many times are they come in and it's, you know, it's something else? So you always need to think about the patient telling me something. Let's move on. So this is the often missed. So there's some examples of things that are often missed, and there's a good list of these in Murtaugh's handbook. I'm not going to read them all out. I'll just let you have a quick look at them. Okay, let's move on. Okay, now the reason that I think the red flags are very important to consider was I went to a conference a couple of years ago about it was run by SIDM, which was a society for what was it called, for not missing diagnoses. I can't remember what the I stood for. Anyway, so considering Murtaugh's red flags, the malignancy, the infection, and the infarction, and the VIN, vindicate, which is vascular, infection, and neoplasm, which is the same as malignancy, infection, and infarction of Murtaugh, the same 3. Those conditions make up 70% of complaints to the New South Wales HCCC. It's either a missed or a delayed diagnosis or being mismanaged. So if you don't think of them, you're not going to diagnose them, and you might end up in front of the HCCC. So those 3 are really, really important. And I think it's so important to teach registrars that they need to think of them. That's it. Thank you. Society to Improve the Diagnosis in Medicine. And I was actually really sad to see that closed last year. So it was it was a really great conference, the Society to Improve the Diagnosis in Medicine. Yeah, but they've actually shut down. It's hundreds of complaints. 70% of all the complaints to the New South Wales HCCC are made up of vascular malignancy. So infection is sepsis, pneumonia, any sort of infection. Infarctions are, sorry, Sarah, infarctions are heart attacks, PEs, strokes, DVTs, and malignancies are all sorts of every cancer. So you can imagine how many complaints go to the HCCC about those things being missed or delayed. I mean, just delayed cancers, I'm sure there's hundreds of complaints go to the HCCC. So there's lots. Sorry, Sarah, what were you going to say?
That's okay. There's a question here. Aren't some of the often missed red flags, for example, foreign body in a child's airway?
Yes, but they're not the big red flags like these ones. Yes, they are. They are red flags, but these are the big red flags. I'd be really interested to see how many people actually use them. There's been some comments about using prompt, but it'll be interesting to see if people actually do use them in their everyday practice. Anyway, we'll move on. So illness scripts. So illness scripts, it's a clinical reasoning tool, and we retrieve relevant information about a particular condition. So we use illness scripts to compare and contrast a patient's clinical presentation, that is the patient's script, against our own mental models of a disease, which is our own illness scripts, as we reason at a working diagnosis or a final diagnosis. So illness scripts change as we get more exposure to the condition. So we hear about conditions from other people, we read about them in textbooks or in journals. So the illness script that we had as a first-year medical student is very different to what we now have as a very experienced GP. Illness scripts are specific to each person. So your illness script will be different to my illness script for a condition, and they'll have differences compared to your colleagues, because we all think about things in different ways, we store information in different ways, and we all have different experiences with illnesses in different ways. I hope that makes sense. Can we just look at the next slide? Okay, so when we gather data, it can be organised into different categories. One way we use are the 4 W's plus never miss. So when does the illness occur? Does it come on quickly or slowly? Incubation periods, etc. Who? It's about the risk factors and the exposures. So, for example, who gets rotavirus? Who gets shingles? You know, it's about the risk factors and who gets them. Why? The disease mechanism. So, when we look at the why, that helps you to increase your knowledge of the condition, and what key diagnostic findings of the disease are important. So, you know, like pneumonia, there's a specific finding on a chest X-ray. Chlamydia, you'll find that on a lab test. And then the never miss, the features are linked to increased mortality and morbidity if the disease is missed. Okay, let's go to the next slide, please. So this is again just going back over the when, who, why, and what. So the when, it's about the tempo. So, you know, for example, if a child's going to get croup, you know, they usually, like day 1, they get the fever and the coryzal symptoms, and day 2 is when they start getting the stridor. So that's the when. The who is the risk factors. So obviously you're not going to get malaria unless you've been to a malaria-prone area. So you have to have been travelling. The why is the pathophysiology, and the what is, as we talked about, you know, looking at the investigations. Okay, let's go over the page now, please. Oh, that was a fading one. Okay, so this is just an example of an illness script with croup. So you can see the epidemiologies, the WHO, children 6 months to 6 years, the pathophysiology, the timing is acute, so that's the when, the clinical presentation, which you all know, and then we don't need to worry about the management because you all know that. But that's just what we know about an illness script. And so an illness script is something you can write on a card. You know, you can just write it on a 3x5 card. But some people might have an illness script that can fill a textbook. So I might know a lot about, you know, pediatrics. Like Solly was a pediatrician in Argentina. So her illness scripts for pediatric diseases are probably really, you know, rich and big, and she can, you know, write pages about all these illnesses. But when it comes to something like von Recklinghausen's neurofibromatosis, her illness script might be that she can only write on the back of a postage stamp what she knows about it. So our illness scripts are all very, very different. Okay, let's turn over the page. Okay, now the other thing that's important with script theory is that our brains interpret the world by looking at the attributes of the mental models it creates with the features of an actual scene. And we check for consistencies and discrepancies. We check for patterns, and we check for irregularities. So the picture that you can see there is a picture of a restaurant. So in a restaurant, what you expect to see are tables and chairs. You expect to see the lights, a nice clean floor. You might expect to see the tablecloths, maybe flowers on the table, knives, forks, plates, etc., etc. But you don't expect to see an elephant in a restaurant. And the reason that this is important is that if you have a patient that comes in who says, I've got a headache, and my headache is on one side of my head and it's throbbing, and, you know, I'm having, you know, I've got you know, the light is hurting my eyes. What's the first thing that you think of? Exactly. You think of a migraine. Okay, so your illness script for migraine is that it's a throbbing unilateral headache with photophobia. Okay, but if then you examine the patient and you find that they've got a temperature of 39 degrees, that's your elephant, because the elephant does not fit the illness script, that the temperature, the fever, does not fit the illness script of a migraine. So you have to start thinking about other things apart from a migraine. I hope that makes sense. If anyone has any questions about that, please let me know.
Alison, there's just a question here. Would you approve that making mistakes is the best teacher of diagnostics?
It's one of the teachers of diagnostics, yes.
I would argue that reflecting on the mistake is the teaching, not necessarily.
Yeah. And I think we all make mistakes. Everyone makes mistakes. But if someone makes a really serious mistake, it can be really devastating, which is why we try and teach people how not to make mistakes. Does that make sense? So yes, if you make a mistake, it certainly teaches you, but as Solly said, you do need to reflect. But I think there's other ways to teach people as well, apart from just making mistakes. Yeah. And we wouldn't want that to become a pattern. Mm. Yeah, exactly. You don't know what you don't know. All right. I just recently went to Tanzania, and that's a lovely elephant from the Tarangire National Park. So I was going to say let's put Richard's story together, but you're all saying that you can't remember what the story was, so it's going to be a bit tricky to do that. So let's just go on and not do that, because no one's going to remember it. All right, how do we teach clinical reasoning to our registrars? And we're running out of time anyway. So let's teach clinical reasoning in practice. So one of the best ways I can think of to teach clinical reasoning is to teach registrars how to use a diagnostic framework. Get them to think of the probability diagnosis, or even a couple of probability diagnoses. Think of one or two red flags. Look at and see if there's any other diagnoses that they've missed. Are there any masquerades? And is there anything that the patient could be telling me? Think about what that list of differentials brings up, and then ask them to look at what features of the history match the illness scripts for those diagnoses. Are there any elephants in there? What can be ruled out and what can be ruled in based on the history, physical examination that you've taken? Do you need to go back and take more history? Do you need to go back and do more examination to rule in any of those diagnoses? Okay, next slide, please. Clinical examination is really important, and I'm finding when I go and do clinical teaching visits that a lot of the registrars seem to skip this step. They go straight from history to investigations, and it's so important to get them to do examinations. It's making sure all the available examinations is included when you make a diagnosis. It decreases the likelihood of diagnostic error, and it decreases the likelihood of premature closure because you're missing a piece of information, or you're just basing on a piece of history or one test result. Next slide, please. Asking the registrar to rationalise their investigations. So doing a random paper audit of their inbox as part of their teaching is very useful. Having an audit of their investigations, asking them, why did you do that? Asking them to say, what was your rationale for doing that investigation? How did it rule in or rule out that diagnosis? How did it alter your hypothesis? And did you need to do that investigation? Just checking that. Why are they doing it? Are they still in hospital mode, and they're just doing the test of 20 that they did in ED, or are they actually really thinking about what they're doing? Next one, please. What can't you explain? So what clinical data doesn't fit with the provisional diagnosis? So what's the elephant? One of the common errors is premature closure. So they close the diagnosis before they've got all the information. And then there's another error called search satisfying, where no further diagnostic measures are pursued. Once a diagnosis is made. So you make a diagnosis and then you stop looking, and you miss things like second fractures, or you miss other diagnoses that are very important. Yes, fast thinking may lead to do investigations straight away, but we're talking about registrars. Okay, you all should all know, I'm hoping that you all know about random case analysis, and this is a really, really good way of checking what the unknown unknowns are for the registrars, and checking their clinical reasoning. So we won't dwell on that. We will keep going. I think you were all sent the pre-reading for SNAPS. So SNAPS is a way of getting the registrar to present, and it stands for Summarising the History and Findings of the Case. And I would encourage you to get them to use problem representations when they do that. They'll then narrow the differential by using diagnostic frameworks, analysing the differential and by comparing and contrasting and using your illness scripts. Then probe the preceptor, which is you, asking you a question about the case, plan the management, and then select a case-related issue for self-directed learning. Has anyone got any questions about SNAPS? Does anyone use SNAPS? I think it's a...
We have a question about something else, Alison.
Yeah.
Isn't it better to start with red flags and then explore the ocean for other diagnoses?
I don't know whether... I'm not the expert, okay? I think you can do it however you want to do it. If you want to do it that way, then that's absolutely fine.
Can I add? Interestingly, we had the discussion with the registrar a few sessions ago when we were talking about clinical reasoning. And that's when the principle of Occam's razor came about, and how sometimes the simplest explanation would account for the patient's symptoms. So common things are common. And in general practice, I think it would be reasonable to try to think about the most likely presentation and then use the red flags, making sure that you have ruled out the red flags. Whilst if you're in an emergency department, you possibly would want to first think about the red flags. And then you can think, oh, well, it's not one of the urgent things, therefore the GP can think about the likely scenarios, and that's when we get them back. That would be my thinking.
I don't think I could cope with always having to think about the red flags first. I think that my way of thinking is I think about the probability diagnosis first, and then I check to see that I haven't missed a red flag.
Same.
That's the way I do it. But you know, and that's the way Murtagh put it. So I follow the way he does it. But you're at liberty to do it any way you want. That's absolutely fine. Yeah, common things do occur commonly. But don't forget, there's also another one of the what are they called? Biases. That's called Hickham's dictum. That says the patient can have as many diseases as they damn well please, which I think is my favourite. So it doesn't all have to be explained by Occam's razor. Acknowledging how the patient makes you feel, and discussing this with the registrar and using the discomfort log. So doctors can ignore data that is ominous in patients that they like or they feel affection for, but conversely, they can discount data in patients that they find annoying or difficult. So you've got this, like, it's like a bell curve. So you're ignoring the data on both ends of the curve, but you only look at the data for the people who are in the middle, which I find a bit strange. And they may not listen to patients who are frequent flyers or whom they see as presenting with trivial problems. So that's something to discuss with registrars to make sure that they are actually listening to all the problems that come in. Okay, next slide. So a good GP is a curious GP. So check everything, assume nothing, don't leave loose threads hanging, encouraging registrars to follow up unanswered questions. Can you tell me some more about that? What, when, why, and who questions? Where were we? Okay, this is we're getting to the end now anyway. This is my very favourite photo I took this recently when I was in Tanzania. This is my zebra crossing photo. I sat there and the zebra was standing at the side of the road and I was saying, cross the road, cross the road, cross the road. And he finally crossed. So I've got a zebra crossing. So embracing zebras. If you hear hoofs, think horses, not zebras, which we all know, but uncommon things do occur and they need to be considered. So making sure that you discuss them with your registrars when you're discussing potential differentials, and just make sure that they're sort of kept not in the forefront, but somewhere in there, and just considering worst case scenario medicine to keep registrars and patients safe. I know there's been a lot of comments coming up and I'm sorry that I haven't been able to answer all of them. Next slide, please. Okay, questions.
We don't have any other questions open at the moment. You did have this next slide for us about resources.
Oh, yeah, they're the resources that I used. Yeah.
Now, Alison, one of the tools you taught me for registrars, and this is about raising the awareness of what we actually know, we didn't realize we knew, is to use the illness script as a self-learning tool, as in like have a blank illness script in front of you, think about a topic you want to cover, say diabetes, and try to fill in the blanks on the when, who, why, what, and the never miss out, or like try to have your illness script, trying to fill it up. Once you've done that out of what you actually knew, that is a great way of knowing where your learning needs are. And this is something that when I teach registrars about illness scripts, I try to use it in that way as well, so that they don't go studying or doing things I already knew.
Yeah. That's a good tip for study. Yeah.
Alison, I would really like to thank you for presenting tonight's webinar. It's just so wonderful to hear from you about this topic, something that I know you're passionate about and you're involved in teaching registrars about as well. So fantastic that we can share with the supervisor team too. So thank you very much. Thank you, Solly, for being with us as well and keeping an eye on the chat. And as always, thank you to Hannah for making everything work in the background and taking care of all the events related with logistics. So we're right on time at 8:30. Lots of gratitude for you, Alison, and thanks for presenting tonight. And we might say good night.
Good night.